All right, just in the interest of time, I'm going to go ahead and get us started. There may be some others that join us as we go, but I'll let them in as we continue along. A few things from me before we get started, just to make sure that you are muted and stay muted until the end of the presentation. That just helps with some of the message delivery. We are recording today's session, and I will post it on the website following this presentation. I'll try to give an updated email that tells you when everything is posted from the webinar, which will also include information about how to receive your CME and MOC Part 2 credit. CME disclosure for our presenter, Dr. Lazaron. Faculty of this educational activity has no relevant financial relationship with ineligible companies to disclose.
And in full disclosure, I want to say that I am a family physician who does OB, and as a consequence is a large pediatric practice, but I am not a psychiatrist. But I do want to acknowledge that all those family medicine psychiatry double-boarded colleagues of mine who've really helped elevate my skill set in this area, in the area of, well, maternal mental health in general.
Thank you. And then I'll just give a brief introduction for Dr. Lazaron before we start. Dr. Lazaron specializes in family medicine with a special interest in family-centered maternity care, as well as with individuals with intellectual and developmental disabilities. She received her medical degree from Rush University in Chicago and completed residency training at the University of Minnesota Hospitals. She is board certified by the American Academy of Family Physicians and holds a degree of fellow of the AAFP. She works for the University of Cincinnati College of Medicine, where she recently made the transition to emeritus professor. She both taught and provides direct patient care with the Christ University of Cincinnati Family Medicine Residency, where she sees pediatric and adult patients in the office, hospital, and home setting. Dr. Lazaron has been involved with many quality improvement projects with the Ohio AAP, and she's a champion for the use of QI projects in residency education. Her outpatient practice includes vulnerable populations from underserved communities, including volunteer work at a local free clinic, where she says she is thrilled to be able to provide international healthcare while also sleeping in her own bed at night. Dr. Lazaron has a passion for providing full spectrum care in both the inpatient and outpatient settings. And Dr. Lazaron performed her last obstetrical delivery in the middle of the night 9 months ago. So she says she should be fully awake for today's presentation. Without further ado, Dr. Lazaron.
Okay. Well, we're going to be talking about screening for maternal depression at the well child visit. And I'll acknowledge all of you who do two-generation care, whether you realize that you're doing it or not. Next slide. The format of this is going to involve some questions that hopefully we will answer for this. And let's start with this first question. Has the consistent consumption of chocolate been shown to decrease the likelihood of depression symptoms? This will not be on your final test, but I just wanted to let you know this will be kind of the format of some of this. So in the chat box, anybody who'd like to put in, is it yes, is it no, is it only dark chocolate? And I'll give you a minute to do that. And hopefully throughout this talk, all the questions you have will be answered with references. I've included a fairly extensive reference list in the back for those people who really like to be able to dig into much more detail than we're able to go into in this talk. But I'll have to say, there's a reference for the answer to this. Thank you for everybody who answered. And you go to the next slide. The answer is dark chocolate has been shown to decrease the likelihood of depression symptoms, but there's a disclaimer on this. You have to have at least a full-size Hershey bar, and it should be preferably dark chocolate to make a difference. So, next slide. Here's the real questions that hopefully we will be able to answer for you. Approximately what percentage of women experience postpartum depression? 1 or 2%, 10%, 50%? Next slide. Maternal depression is associated with the following adverse outcomes in children: We are talking about pediatrics here, so let's talk about how this affects children. More missed well child visits and missed immunizations, early discontinuation of breastfeeding, poor scores on cognition, language, behavior that persist into childhood and adolescence, or all of the above. Hopefully, you'll get this right at the end. Question number 3. Which ones of the following are associated with screening or treatment of depression in women during the first 3 months following childbirth? And this is the only one where we have really good statistics. Screening has no impact on the incidence of major or moderate depression at 9 months. It has significant decreases in both major and moderate depression at 9 months. And women who received interventions had significantly better scores and functional outcomes of parenting association and mental health functioning at 1 year. So that could be some or all of the above, or just a few. So, last question on the list for those of you who, whoop, go back one slide. How do I bill for all this work I'm doing? Can I use the CPT code 96161 to bill for caregiver screening for depression in Ohio? Can I only do that at the hospital newborn visit? Is it only up till 2 months of age? Can I only do it at well child checks from birth to 6 months? Or can I do it at any child who shows up in my office who's under 12 months of age? The answer is coming in this talk. Next slide. We're going to go over the whys, whats, and hows. I'm hopefully in the course of this, we will really talk about the incidence of maternal depression, the consequences that happens for infants, for mothers, for families and society, um, and really what clinical features that you doing two-generation care will pick up as part of your general assessment of your infants. All of you who do anticipatory guidance as part of building parenting skills will realize that giving resources for maternal depression is just one more element of anticipatory guidance and are well within the scope of your
Well,
practice.
maybe not for this account.
Yeah, they have to set up breakout rooms and
Okay. And if you're not muted, if you can, that would help. And we're going to do a little,
yeah,
Okay.
yeah.
and we're also going to be doing a little bit of information about how to effectively bill for that if with the time you have
Go
allowed.
online.
Go online, I'll have to open that meeting and edit it.
Okay.
Okay. Can you go back 2
Mark,
slides?
can you Mark, this is Chris. Can you mute your line, please? Thank you.
Okay. Go back to slide number 12, if you can. That's the next slide. Okay. We're going to talk about the whys now. Now, we already have some answers here to the questions. Maternal depression affects infant well-being. Children who are exposed to maternal depression before the age of 1 are at risk for delays in social, emotional, cognitive, and physical development, and higher risk for early discontinuation of breastfeeding and malnutrition occurs. For those of you who track social determinants of health, secondhand smoke exposure increases. A parent with depression is twice as likely to resume smoking after delivery. There's a definite decreased risk for preventative services. They're not showing up for their well child checks to the office on a timely basis, but they are going into the emergency room. And in that emergency room visits, we find that these children have 3 times the increased risk in child abuse. And the scope of this problem is significant. It's been found that 1 out of 8 women report symptoms of postpartum depression after the birth of a child. Next slide. And these consequences continue on. There's immediate and then downstream consequences that affect the child. A lot of this came out of some really pivotal research done in 2016 that was reported in the Journal of Pediatrics. And then JAMA Pediatrics expanded on this further in 2020 with some good statistics. And those references are at the back. Prenatally, we know there's increased preterm delivery, low birth weights, spotty prenatal care. In infants, lower cognitive scores and dysregulated behavior, increased arousal, the baby who cries all night, the toddlers can be more passive, have less creative play. The school age kids have been documented to have more ADHD, more mood, anxiety, and conduct disorders that persist into adolescence and expand. So now that they're also diagnosed with alcohol and substance abuse disorders, depression, ADHD, and learning disabilities. Next slide. Um, the why of this is um, pretty easy to understand because a depressed mom has a harder time responding to an infant's need. This is an adverse childhood experience. And I'd like you to think of maternal depression that way because it affects the pediatric well-being just like the other adverse child experiences that we have. Um, the depressed mom just has more problems with attachment. So thinking of all those kids who have attachment disorder and so have difficulty responding to their environment because their environment doesn't have as much nurturing. The children are more depressed, they have more behavioral problems. That feeds back and they're at risk for harsh parenting. And because of that, these children are very vulnerable to events that affect safety and harm. And their coping ability is diminished with this as well too. Next slide. Um, the ways that young children respond to this when the nurturing caregiver is absent is things like sleep disturbance, that increased arousal we talked about. They become almost hyper vigilant even as newborns. The regression, children return to an earlier stage. So a 12-month-old whose mother is depressed may find themselves regressing in some of their developmental milestones in an effort to get more care. Behavioral changes. These kids are passive and quiet because their parent is irritable or they're easily alarmed. They may be less secure about being provided with the protection they need, or they may respond with aggressive outbursts or hypervigilance, an exaggerated startle, because they need that to be able to get their needs met. And there is definitely that dose response to toxic stress. And these adverse childhood experiences do correlate with much higher health risks in adulthood. Next slide. This is a downward spiral that feeds into itself. The mom with the apathy and the poor concentration doesn't set limits well. The child doesn't learn how to regulate emotions and behaviors. And the mom who's kind of apathetic is unable to model appropriate behavior. So the child acts out till they get attention. And the mother reacts to that and re-exposes to this child to anger and aggression. And so the child learns to expect hostility and aggression, becomes aggressive, and then triggers the anxious mother. The mother becomes frightened by the child's behavior and is unable to soothe the child. And this just results in anxiety and fear for both. This downward spiral just doesn't seem to have an end once it's initiated. Next line. Let's talk about the mom in this. The mom is not your patient, but um, they fall within the purview of your practice when they come into care for their child. Major depressive disorder incidence peaks at 6 to 10 weeks postpartum. Dysthymia, that's the persistent depressive disorder, has some real definite peaks at 2 to 3 months, again at 6 months, and again at 12 months. But most maternal deaths due to postpartum depression occur in that 6 to 12-month time, even though you may be most focused on screening for this in those early first couple of months. Now, why isn't somebody else taking care of that? Well, honestly, the mom gets one follow-up visit at 6 weeks postpartum, and a third of them don't even make that appointment with their maternity provider. Women often stop their own medical care for the first 18, maybe 24 months after a child's born. And remember, this is a common problem. 1 out of 8 women report symptoms of postpartum depression. Next slide. There's a recent wonderful article that just came out last week, and the references in your slide deck, talking about this. Women with perinatal depression have been found to have a 3 times higher risk of suicidal behavior, and that suicide risk was highest for women with postpartum depression in that first year after diagnosis. But the risk did not go away. It may become turned into chronic depression that persists for up to 18 years, which is the limit of this whole study. It was a large, only was almost million women cohort study with a maximal follow-up to 18 years. Next slide. Um, and from a recent, I think it was British Medical Journal article from January of 2024, it's found that 69% of women with postpartum depression, that postpartum depression goes unrecognized. Um, and of those who are recognized are diagnosed, only 6 to 9% of those diagnosed receive good evidence-based care. For society, that's a terrible thing. A single untreated case of postpartum depression can cost nearly $100,000 over the lifespan, and those are recent estimates. And there's some real differences in cultural concerns. While Hispanic and African American women with postpartum depression are more likely to self-report and feel more comfortable doing that at 2 weeks and at 4 weeks postpartum, white women take longer to become recognized, and have really expressed some self-reporting conflicts over privacy and disclosure. If you think about it, I was just thinking of a colleague who really didn't want to talk about her postpartum depression because she felt that this was reportable to the state medical board and it would affect her licensure. So you understand why these conflicts can happen, but also can be just being not perceived as the good mom if you admit to depression can also be a factor. Next slide. So being on the lookout for this is helpful. We need to be an advocate for women. And there is excellent evidence. Um, they found that just the act of screening, even if you don't get treatment, improves the, the outcomes in women with postpartum depression. Screening alone and having somebody acknowledge that you have depression, putting a label to this, improves the depression rate at 9 months. And there have been some good looks at which screening tools we use. And definitely we found the Edinburgh is more reliable than the PHQ-9. PHQ-9 has a couple of somatic questions in it about how well are you sleeping and has your weight changed recently? That really probably applies to any woman who's in the first few months postpartum. And those questions are not part of the Edinburgh, so they may be a more reliable screen. They have not found any harms associated with screening. You're not going to induce somebody to commit suicide because you talk about suicide. And then definitely treatment helps to improve outcome. For mild depression, cognitive behavioral therapy or interpersonal therapy is shown to be even better than meds. But any treatment improves depression and functional outcomes at 12 months, even referrals just to support groups. And are there any harms that we need to be watching for as we recommend treatment for these families? There's some very low incidence of side effects from medications postpartum, but not for the interpersonal therapy. So feel free to recommend families get treatment for these disorders. Next slide. Why aren't women getting this? Because 35% of women don't keep their postpartum appointment. That would be the access point. You'd think that people would pick up on this. Why not? Well, one of the reasons could be us. They're always at the pediatrician's office. When you think about all the visits we have, the newborn, the 1, 2, 4, 6, 9, 12, 15, 18, and 24-month visit, that's a lot of visits. And that's not counting the weight checks we throw in, the acute visits for illness. And you can make a difference with this. Depression screening at 1, 6, 12-month-old well child check, and this was an old study where they only checked at these 3 intervals, picked up 13% more women at a high risk of depression. The AAP, based on their studies done in 2016, recommended screening at the 1, 2, 4, and 6-month well child check. And U.S. Preventative Services Task Force in Ohio Department of Health now recommends that we screen at all the well child checks through the first year of life. Next slide. Um, but there's also some things that even if you haven't screened that you'll be able to pick up on. There's some risk factors for postpartum depression that become obvious to you as a clinicians that are maybe part of the child's chart or your interaction with the family that'll make it a little easier to sort this out. Um, the mom with the unplanned C-section, the preterm delivery, a low birth weight child, anemia in the mom, the child who is born with significant unexpected medical needs or disabilities, the extreme preemie, the child with Down syndrome or other developmental disorders, um, a mom who already has a history of depression or PMS before pregnancy may be more prone to depression. Women who have adverse social circumstances themselves, lack of support, domestic violence, being a single parent. And then simple things in the environment. Lack of sleep affects depression. Um, Smoking affects depression. Um, Whether they return to smoking because they're depressed, which definitely happens, or um, the continued smoking seems to be associated with increased maternal depression. And there's some clinical outcomes that you may see that may really raise some red flags. That family that has frequent missed or canceled appointments, they give up breastfeeding at an early stage. Breastfeeding itself has been found to help um, prevent postpartum depression. Those people who continue to breastfeed exclusively through 3 months of age have much lower rates of postpartum depression at 3 months than women who are bottle feeding. And you'll definitely pick up those people who have a lower confidence in their parenting skills. Next slide. Um, I want to talk just briefly about what evidence you know will work for those people you identify with postpartum depression. I put both the um, Edinburgh score and the PHQ-9 in as a comparator there for somebody who has no or minimal depression. Just the act of rescreening and offering social or peer supports as you think this family needs it seems to help prevent more depression. So if you have a sense that they could use more support, offer more support. For mild depression, cognitive behavioral therapy or interpersonal therapy is considered first line. If they need additional therapies, then considering an SSRI is what is called for. And somebody with moderate depression, a PHQ-9 of 10 or greater, do them both. Throw everything at them. Do interpersonal or cognitive behavioral therapy plus an SSRI and refer them to social and peer supports. Every child succeeds. Um, early Head Start, breastfeeding support groups, so whatever you can find, parenting support groups that you can find in your community. Now, I have to say, in severe depression, what you most want to have is that list of reliable consultants that you can refer those patients to, because this is the tough crew. These are the people where you want to start the SSRI first, and only start the interpersonal therapy after they start improving, when they can actually benefit from that. These are people where second line treatments like SNRIs or third line, there's even some rapid active therapies now that are administered by continuous infusion IV and are usually done in the hospital, like brexanolone, which have now come into play in the last year that can be helpful. Again, you're going to need a consultant for that. So finding your list of consultants and using them heavily is a great resource to be able to offer families. Next slide. And why are we talking about medications? You may or may not be prescribing. You may, but those of you who are using a lot of sertraline for teenagers in your practice may be very comfortable starting an adult patient in your practice on sertraline. And knowing that for those people who do have um, moderate depression, the SSRIs are preferred in first line. But families will come back to you because you are the expert on their child and they want to know whether or not these medications are safe to take as a breastfeeding mom. So here's the scoop. SSRIs, sertraline and paroxetine are the ones that are preferred. All of these that are listed here have a very low relative infant dose. That's how much gets into the breast milk relative to the mother's serum level. So all can be used, but some are better than others. Second line, SNRIs, we prefer venlafaxine over duloxetine. And if you need to use the tricyclic antidepressants, nortriptyline is the one with the best safety track record in breastfeeding women, just to avoid doxepine. There's been some infant sedation that happens with that one. Next slide. Other things that you may feel are well within your wheelhouse have been found to make a significant improvement in depression. Motivating our moms, screen, offer education, and then permission for a phone call for follow-up. Just doing that, identifying the issue and saying that you're concerned are going to follow up means 20% more of your family members will go out and search out the resources that you give. How many times have we given people a handout or put something on their after visit summary to find that it has hit the trash can before they've even pushed the button for the elevator to go down to their transport? When they know that you're going to follow up with them, they actually seek out some of the advice you give. Find your local community partners. Head Start and Early Head Start are favorites of mine. Any infant or early childhood consultants you can find. In my region, Every Child Succeeds has an arm that also helps with maternal depression. And find your local list of resources for moderate and major depression, who may provide individual CBT, interpersonal therapy, medication. Find your favorite perinatal psychiatrist. When we talk about some other resources you can find, but I did put a long list in your reference list as well. Motivating our moms is something that we can all do. So next slide. Here's some national resources. Can do the National Maternal Health Hotline. I love the name. TLC Mama for postpartum women. It has a confidential hotline for women in English or Spanish. Just if they're actively suicidal, please use the 988, the Suicide and Crisis Hotline. Next slide. A wonderful resource is the list of treatments that is offered through the National Alliance for Mental Illness. And they have a special section on postpartum depression that includes some groups, blogs, in-person support groups offered in other languages. Spanish is the easiest to get, though there is some other languages that are offered. And I just want to point out that there's also postpartum men. The name for this website is called Sad Daddy. And what is the biggest risk factor for depression in men in the first year after the birth of their child? Having a sad partner. If the mom's depressed, everybody's depressed. If mom's not happy, nobody's happy. Next slide. Now, how are we going to do all this? We got a zillion things to do. Well, I have to tell you, pediatricians are the champions of being able to screen. When I think of all the things that get screened for, the in the part of the developmental screen, the SWIC, the MCHATs, the ASQs, the Vanderbilts. If there's anybody who knows how to screen for anything, it's a pediatrician. The quickest way to screen is if the child's a patient at the well child visit, screen the parent for depression with a quick PHQ-2. It's just 2 questions. In the last 2 weeks, have you been bothered by the following problems, little interest or pleasure in doing things, or feeling down, depressed, or hopeless? If that screen is positive, then you can either give a PHQ-9 or an Edinburgh. Now, PHQ-9 can be given for any caregiver who's there in the room with the patient, whether that's an adoptive parent, the father of the baby, grandmother who has become the guardian or parent for this child. And Edinburgh is specifically for birth mothers, and it's used at the 0 to 12 month well child check. Next slide. How are you going to do this? You're not going to do all this by yourself. You're going to get the team to help you. So at the well child check, have your MA ask the PH2 questions just as part of the rooming process. And if the screen is positive, enable that MA to go ahead and turn around and give the parent the assessment form so that you can review that later with them. Next slide. Um, and you need to know that you can code for this. This is a billable service that you are providing for this family. If the child's the parent, you can use the PHQ-9 or the Edinburgh to assess the parent for depression. Use the CPT code 96161, which is administration of a caregiver-focused health risk assessment for the benefit of the patient. ODH will pay for this screening at every infant visit from birth to 1, whether it's a well child check or an illness visit. Now, it doesn't pay that much. It pays $3.43, but hey, that keeps the light bulbs on. And commercial insurance can be shown to reimburse this as much as $30 or not at all, depending on um, that insurance. So use the ICD-10 code, Z13.31 or 13.32. Both will get this paid. When we're talking about making changes to our workflow, especially ones that may require more IT support, it's really nice to go back to your administrator with the information that the system is going to acquire more dollars to support these changes by making these changes. So this is what you like to be able, this one slide, take to your administrator. Next slide. Now, if your screen is positive, what are you going to do next? Let them know you're here to help, that their health is also important. Ask them if you can check in with them at the next visit and offer those resources that they can have in their hand when they go out the door. Some of the local parenting resources and support groups are a great place to start for the breastfeeding women, the baby cafes in our region, Amen. They Bless Our Beautiful Sisters Breastfeeding Support Group with the wonderful acronym of BOOBS, and Leche, which is the breastfeeding support for Hispanic women, are all great support groups for mom. Both in Cincinnati and Cleveland, we are hotbeds of centering, and so centering parenting groups are a great place for parent support. And ODH now has a free resource of the Triple P Positive Parenting Program, and the reference to that is in the end that parents can use to improve their parenting skills. Next slide. Um, be prepared with those community referral resources first. There's kind of no point in screening if you don't have something you can offer, but we screen because we can help. And community resource support alone has been shown to um, provide improvement in depression scores at 9 months, even if they have mild depression. So remember, anything you do, whether it's screening and any referral just to community supports, is going to help that family. And remember, if you screen, you offer education, you ask for permission for a phone call for follow-up, when you do call up, you find that 20% more patients have contacted their resources just because they know you're interested in checking in on them. Next slide. Okay, how are you going to actually do this and have it work? So you can use some EHR tools to help with documentation follow-up. Consider adding one of the following following ICD-10 codes to the problem list, like uh, P0089 for newborn affected by maternal depression, Z62.9, which is a history of adverse childhood experiences. Caregiver depression is definitely one of those. You don't do this alone. You can route this note to staff for a phone call follow-up. Use reminders to screen for depression at the subsequent visit, like sticky notes, to ask them how they're doing. Um, there is also, for those of you who are into billing, there's a brand new HCPCS code that came up just in January this year, G2211, which you can use in addition to your well child or other E&M code at those office visits that require more complex care and referrals. And if maternal depression doesn't add to complexity of care and referrals, I don't know what does. So use that too. Next slide. Now, you can make depression screening work for you by working a little smarter rather than harder. As a standalone event, building yourself a documentation smart phrase that includes that diagnosis and billing codes in it makes it much easier to remember this. and empower the staff to use that depression screening tool at the same time as any other standard child development screens that you do. Now, as a standard, and you might want to be using this, say, for a visit, which is an illness visit for a child you're doing a little catch up for. Now, as a standardized practice, using these screening tools within your standard well child note template means that your ability to remember and act on this is going to be improved. Um, if you use preference lists or smart sets, adding those billing and diagnosis codes directly to that, and establishing practice protocols for allow staff to place these charges for you or to have them automatically placed for you to be able to review and sign later also improves this. Next slide. There's some definite ways that you can make a difference for this in fee-for-service billing. Remember that medical decision making is can be time-based billing if you document the work. The HCPCS codes G2211 is an add-on code. Now CMS, so if your patient's on Medicare, will pay $16 for this in 2024. We don't know what commercial insurance is going to pay for this yet. And in those people who have value-based contracting, documenting consistent screening referral for some element of social determinants of health is usually the basis for added payments to the medical home as well. So if you need to motivate some administrator to give you some resources to be able to carry this out, this is also a slide you show them. Next slide. We're going to be breaking out into some sessions here to be able to go over case study, but I want to go over this case study and run it through you with you real brief before we break out into our breakout sessions to just talk about this. This is with some minor changes to protect the identity. So a real patient of my practice that I want to talk about this and see if in the course of our discussion on our breakout sessions, we can talk about which identifiers really create some red flags for maternal depression. This is a case study I called Matilda Has a Baby. And as a background, you're so pleased when Matilda calls your office to ask if you're taking new patients, and would you be the doctor for her newborn daughter, MJ? Matilda was a patient of your practice from early childhood when she moved until the time she moved away to attend college. You really remember her with pleasure, taking care of this bright, energetic individual. She was the first in her family to finish high school and attend college, which is nursing school. Um, and Matilda was was usually accompanied to her visits by her grandmother, as her home life had some challenges with unstable housing and parents with substance use disorder. In addition to well child care, during her adolescence, she was also treated for asthma, headaches, and briefly required treatment for depression and complicated grief in high school after the death of her beloved grandmother. Now, at the first newborn visit, MJ is seen 2 days after the hospital discharge, accompanied by both parents and the paternal grandmother. She's a term breastfed infant who passed all of her hospital newborn screens, but she was noted to have limb differences with syndactyly of the second and third digits of the right hand and a shortened forearm. You referred them to Help Me Grow due to the limb differences and for a consult with a peds plastic surgeon and asked that they return for a weight check in 1 week as she's not quite back up to birth weight yet. Next slide. At the 1 week check, it gets rescheduled on the day of the visit for 10 days due to some issues with transportation. But the baby's back up to birth weight, and the mother's now supplementing with formula at the nighttime feedings. At the 1 month visit, both parents come for MJ's visit. She's now bottle fed as the mother's back in school already. Um, Good weight gain, but has not made contact or an appointment yet with Help Me Grow or the plastic surgeon you gave the referral to. The father's concerned that the baby's not sleeping through the night yet and really needs some help with some parental guidance about when babies sleep. At the 2 month visit, MJ received her immunizations. The mother's concerned the baby won't be able to hold her own bottle due to this limb difference with the syndactyly and is concerned that the baby's not holding her bottle on her own yet. At the 4-month visit, it gets rescheduled twice due to lack of transportation, and so you don't see this family again until 6 months. At that time, you do a catch up of the missed 4-month immunizations. MJ's weight gain has been appropriate. Developmentally, she's able to roll both ways, sits with support, smiles and babbles. You find out the mother's dropped out of nursing school. She missed the appointments that were made to the plastic surgeon and is not rescheduled, and she hasn't returned phone calls to help me grow, according to the agency notes. Now, looking through that, I'd like you to be able to highlight some of the red flags that you would see that make you think, something's going on with this family. If we can break out into the breakout sessions now, I'd love to be able to talk with this and within a smaller group, and we'll get back together at the end for a little bit short wrap up.
And Dr. Lazaron, this is Chris again here. Mark and I are encountering some technical difficulties with our breakout rooms. So we're going to all be staying together for this part, which I don't think is bad anyway. We have a little bit of a smaller group than we were expecting today. So we're going to be all together. Dr. Romano and I will also I'll be watching the chat box. So this is a great case for us to discuss. And I think we're going to have a good, rich discussion. I'm kind of actually glad that we're going to get to hear your take on this as well. So if people have questions, we really would love for you to chime in. Feel free to unmute yourself if you have a question. If you prefer, please feel free to use the chat room. And like I say, I will be watching the chat room as well. And if you would rather that I ask the question for you, that would be great. We also have some prompt questions. And Dr. Lazaron, would you like to hit the prompt questions, or I have some questions myself too?
Yeah, go ahead. Why don't you jump in, Chris?
You know, one of the things that I think is you made a comment, and through the PHP program, we had a really good comment made about screening without things. You know, why would you ever, you get the common thing. If you don't have anything to do about it, don't ask the question. And our participants in PHP, one of them, I can't even remember who it was, really had had a really great comment in one of our improvement sessions saying like, well, there's a lot of reasons to screen, even if you don't know. You brought out a lot of issues for the patient, like just bringing it to their attention. But our providers also made a comment saying like, if you don't know this is a problem in your practice, you're not going to know to go looking for you're looking for solutions. But if you screen, even if you don't have a place to go with them right away, at least it then rises to a level where you go like, wow, it's better to know than not know. Kind of the first step is knowing that it's actually a problem, whether that's maternal depression or diabetes or obesity or hearing problems. If you don't know it's a problem, you're not going to be able to fix it. So I'm really grateful that you made the comment like screening in and of itself is useful.
You got to count it to know that it's important to you or how important it is to the system. But also putting a label on this for a family is also therapeutic. Just having knowledge that this is not expected is powerful.
Yep. And you're not alone. So, if my doctor's office is asking about it, then I'm clearly not the only person that they ask this of.
Anybody want to come off mute or put anything in the chat box about any red flags they saw in our Matilda case?
Hi, my name is Stephanie. I'm not sure if everybody can hear me.
We sure can, Stephanie. Please go right ahead. Thank you.
All right, so just commenting on a few of the red flags would be the missed visits and the fact that Matilda's dropped out of school and hasn't returned like phone calls to the agencies that she was referred to.
Yeah, definitely. Those people that you've found some issues and offer some resources, but they just don't have the wherewithal to be able to do that, could be a red flag that there's something else going on here. So
feel free to put red flags that you see in the chat box too.
Hi, this is Judy. I think it's really great the way, well, your presentation, all of it has been wonderful. And the fact that you know Matilda so well, you already have a relationship with her, and that's great to build on. And I think, as Chris was just saying, realizing that our relationship with our moms is absolutely the cornerstone to everything. And then knowing Matilda, you know what her background is. And as you look through, she has a number of things that are setting her up, some adverse childhood events, if you will. And I think that's really important that you keep those in mind too, not just what's happening right in this moment in time, but what's happened to her in the past. Some of the things you mentioned, she comes from a family that was disrupted with substance use disorder. And then, of course, the social things that fall from that, unstable housing. And thank goodness she had somewhere to land with her grandmother. But my gosh, she lost her grandmother when she was still a child herself, still in school. So all of those things can result in setting her up to have a really profound experience when she then goes to become a mother herself.
So thank you so much for noticing that. Yeah, those are some of the things that I think were help when you are doing that two-generation care, because the longer you're in practice, the more families come back to you and bring their grandchildren back to you, even because they honor your care. And so you are nobody. I remember the sad day when my pediatrician took me out to the waiting room, pointed out all the small chairs, and said, "It's time for you to find a real doctor." Not a real doctor. He meant a grown-up doctor, but he used the word real doctor. Um, and how sad I was, and how I continue to always think of him as my doctor, even when I was in my 30s. So that warm feeling that you have about the person who was so important in your child development is very real and continues onward.
So, one thing that caught me, I was wondering too, if anybody else thought about that, the comment about the limb difference in the syndactyly, because that one caught my attention.
Yeah, I think that makes a difference. If you have a child who's got some developmental differences, um, the feeling of Um, I was expecting to go one path and my path has now changed. My child is not the perfect child. Even if it's something that's fixable, remediable, um, this can affect how parents bond with that child, or their expectations of the newborn period. Um, and some of the unrealistic parental expectations, like um, thinking a child should be able to hold their own bottle at 2 months of age, ascribing that to the fact that the child had a developmental difference rather than the fact that nobody holds their bottle at 2 months of age, may be impacting that as well too. So um, I was uh, most taken with the fact that at the newborn visit, this child seemed to be surrounded by people who wanted to come to the newborn visit with her. The father of the baby, the paternal grandmother. There was actually a couple more people sitting out in the waiting room who we just didn't let back in the room because it was a little crowded. And all that support kind of melted away over the course of that first year of life. The I don't have a ride, I don't have somebody with me helping me bring the baby in, just seemed to vanish once the new baby glow was gone. So um, I'm going to go over some of the red flags I pointed out here. If you want to advance the next slide. And you picked up so many of them, Judy, too, about being the first in her family to finish school, unstable housing, the fact that she briefly needed treatment for depression, um, the child having a limb difference, which can affect families' connection to the newborn. Next slide. And then the fact that these visits keep getting rescheduled. The mom was now supplementing with formula for the nighttime feedings at 1 week of age, and by 1 month was breastfed. can be a flag. The fact that she's back in school tells you that just enough rest and time to recuperate. I mean, who doesn't get 12 weeks postpartum leave? Well, anybody who needs to continue to their education program or needs to put food on their table doesn't get 12 weeks postpartum. But that lack of sleep also affects postpartum depression. Um, the decline in the supportive presence of others once that new baby glow is gone, I think is something I talked about. Um, and so, anytime you see some of this, being able to intervene, even if you're not labeling it depression yet, but you're noticing that things are falling off the list of best options for this family. Maybe referring to a lactation consultant at that 10-day visit when they're now having to supplement. Finding when you have fathers asking silly questions about babies sleeping through the night at 1 month of age, giving them some parent information classes may be helpful. These are things that you can do within your wheelhouse. If you want to go to the next slide, this is where her depression screen fit. When she came in for her newborn visit and everything was rosy, she had just done an Edinburgh in the hospital and it was 0. Next slide. By the time she came back for that 1 week check, you didn't screen again because it was just been done 2 weeks before in the hospital and didn't think that was an issue. Well, probably should have done it. There was probably some things happening then. By 1 month, you did a PHQ-9, which showed that she was a 4, which is minimal depression. And most of the things that were coming up were sleep and fatigue and weight loss, all of which you kind of say, well, is that normal for 1 month of age? Possibly in Edinburgh would have been a better choice at that time. By the time she comes in at the 2 month well check, um, her PHQ-9 is 7, which is telling you that she has early depression. And she's now having more problems with concentration and fatigue, in addition to the issues with sleep. Never got a chance to screen her at 4 months. And you'd already done some referrals to Every Child Succeeds or to Help Me Grow for this family. So you thought maybe they were set with some resources. Next slide. By the time she returned at 6 months after those missed appointments, you found that a PHQ-9 was 14, which is moderate depression. She had little interest in pleasure, in activities, her sleep, fatigue, depression, and feelings of failure had all starting to become almost overwhelming. And my takeaways for you is that a screening early, screening often, screen if you've just screened a week and a half before. Maybe considering it in Edinburgh, you might be able to pick up things that you find are more actionable. If you've got one of those borderline results on a PHQ-9, because it eliminates some of those questions about weight loss and fatigue. And it's okay to refer for help early, even if it's not depression help, when there's any of those red flags present that you feel like a family could use more support. Next slide. I want to go over some of those questions here first, the answer to those questions for those of you who didn't pick it up in the end. But I want to ask first before we jump into this, is there any more questions either from the chat box or from the presentation that people have?
So we have a great question from Dr. Halloran. Have the rates of postpartum depression increased over the past years with the decrease in community connection and increase in loneliness? And a follow-up, do you think acknowledgement and treatment for postpartum depression mitigated any increase in postpartum depression due to increased loneliness in society?
That is a great question. The studies that have been done have had the rates of postpartum depression anywhere between 7% and 13%. Now, some of those studies were only done through the first 3 months. Some of them were extended out through a year. So 10% seems to be a nice average in there. The things I would guess that the degree of isolation and loneliness probably plays a big impact in this, in only that some of the treatments that increase social supports have been found to be very beneficial in depression. Those people who have parenting skills groups or um, lactation support groups, who do group model prenatal care or group model well child care, all seem to have improvement in depression, um, as well as a lower incidence of depression in people who already have those resources in place. So I do think that this is probably a factor that's become more common for us. When we had multi-generations living in the same household, there was probably more support for that new mom than there is now.
So another question coming from Anna Winfield. Anna says that she has routinely screened for moms in this manner for several years, and I'm interested in expanding it to non-mother caregivers. Can it be billed and coded in the same as screening for biologic mother?
Yes, there is a similar code that's 96160, which is screening a caregiver for depression. Now, ODH doesn't have it scripted that'll always get paid, but it is a known CPT code. It can be used. And I use that 96160, the screening of a caregiver for depression, liberally across many settings. I sometimes use that as a family physician for screening the adult child who brings in the aged parent that they're now caring for caregiver depression. Um, so that has been one of the things in my armamentarium that has been very useful. The 96161 is specifically for maternal depression, but 96160, which is screening for caregiver depression, is also a very useful thing to have.
Great. I'm dying to see the answers to our other questions, Dr. Lazaron.
Okay, so question number 1. What percentage of women experience postpartum depression? Approximately 10%, not 2%, not 50%. It's 10%. Next slide. Maternal depression affects the child in all of the above. Ding, ding, ding. More missed appointments, early discontinuation of breastfeeding, poor scores on development, cognition, language, and behavior. And that persists all the way into adolescence. Next question. Which of the following is associated with screening or treatment of depression in women during the first 3 months following childbirth? No impact? Nah, you can have an impact. And what we found is there's significant decreases in both major and moderate depression at 9 months postpartum just by the act of screening. And those women who received intervention also had better functional outcomes when they were screened, when their outcomes of parenting, anxiety, and mental health functioning, even out at 1 month postpartum, that persist. So screening helps, giving treatment helps even more. Next slide. So when can I use the lovely code 96161 and get paid for caregiver screening for depression? The answer is, in Ohio, all infant visits from birth to 12 months of age, illness visit, well child check, weight check, they're in the office with that mom, you go ahead and screen. Next slide. I'd like to acknowledge all the people who helped with facilitation for this in the Ohio chapter of the American Academy of Pediatrics, the Ohio Department of Health, which helped with supporting this lecture series, some personal acknowledgments to Dr. Emily Harris, who's a pediatric psychiatrist in our region, who helped me with finding some local and regional supports for maternal depression, and the grandfather of the implicit as well as advanced life support and obstetrics program, Stephen Radcliffe, who's been my mentor and guide in many of these things through my career. Next slide. I have a whole list. I have 4 pages of references for you. Those of you who like to get into references, these are all the references with hyperlinks to being able to read the articles that informed much of this talk. The next slide is references for people who want to know more about billing, including E&M coding, the G2211 add-on code. There is also a link for the Edinburgh Postnatal Depression Survey. It is a free survey, and the download is from the aap.org to be able to implement this in your practice. And there's also some references about social determinants of health coding too. Next slide. Some additional references, because we know breastfeeding is protective for depression. The breastfeeding hotline that is being promoted by the Ohio Department of Health is here for you to add to your list of resources. And then the last slide is some referral resources for mental health, parenting, community supports. I have both national ones like the NAMI, and then some Ohio resources with hyperlinks to be able to look and see if any of these are useful. I really want to highlight that positive parenting program, or Triple P, which is a free online program to improve parenting skills. The Moms Group for Ohio Southwest Breastfeeding Coalition has resources to all the different breastfeeding groups in the region. There is a organization out of Central Ohio in the Dayton region called POEM that also does home visitation, as well as Every Child Succeeds, which is in Southwest Ohio, that does home visitation and also focuses on depression as well. There's a couple of videos that have been great resources for use in well child checks for those who would like other resources to hand to parents, like the Spark videos and Caring for Your Newborn, which are also free downloads too, that I want to point out to you. And hopefully some of these will be helpful to you in your care of infants and children.
Dr. Lazaron, thank you so much. I'm going to turn this back over to Mark here. I just wanted to mention too, there are a couple other references that Dr. Romano will throw those in there for you. Something from Sunday morning from the Ohio Department of Children and Family Services that are my chat box. We'll also get those to you, posted as well. I'm kind of glad we didn't have breakout rooms, because we got to hear Dr. Lazaron and her expert thoughts the whole way through. All of us did. So with that, I'm going to turn it over to Mark, and Mark can wrap it up for us here.
Yes, thank you, Dr. Bowling. I'll just quickly close us out to be respectful of everyone's time. I will be sending out that follow-up email that will give information about obtaining your CME and MOC Part 2 credit for this presentation, as well as links to this slide. And we have a really good resource available that has a lot of the information that Dr. Lazaron talked about right there for you on a single page. So that will also be linked in that email. On these slides, there's a couple education opportunities coming up. We have a really good slate of topics coming up for our PHP program, including newborn screening, diabetes, ADHD, and anxiety. So look for those registration links coming soon as well. And then this diabetes link will be in this presentation. You can also sign up for that. And then, of course, once again, I just want to thank Dr. Lazaron for an awesome presentation full of wonderful information. And then Dr. Bowling, Dr. Robinson, and Dr. Romano for being available if we were going to get into breakout rooms. Thank you so much for your time. I hope you all learned a lot today. If you have any questions about the program, you're welcome to send those to me. My email will also be, my email address will also be in that email, so you're welcome to reach out to me. Otherwise, I hope you have a great rest of your week, and we'll see you at the next webinar. Thank you.
And the reference for the dark chocolate is at the bottom of the reference list too, for those of you who need to throw that into your next PowerPoint presentation.
There you go. Have a good day.